How's it going, guys? Very fucking high yield question for Obs Gyn for 2CK. We've also got some psych in here. Holy shit, right? Psych. This is pass level. You cannot miss this type of question if you have any chance of performing decently on your 2CK. I'm not intending to fearmonger and be an asshole, but this is very fucking important. All right. So before we get started, please subscribe to my channel. I really appreciate it. Give the video a like. Really appreciate it. Find me on Instagram, Mehlman_medical, MEHLMAN_medical. Link is down below. Find me on Telegram. Recently created a Telegram group and channel. Links are down below. And you can join this channel, become a member. Button is also down below. Now let's hop in the question here. 34-year-old woman, G3P3. She has a 3-month history of current episodes of urinary incontinence. The past week, the episodes have occurred 6 to 10 times daily. Unpredictable, sudden urge to void. Does not make it to the bathroom on time. She sometimes feels the need to void when sticking the key in the front door of her house or in her car door. She reports decreased visual acuity in her left eye, reduced color vision. Questions asking the most likely explanation for these findings. Now look, they use the word urge here. This is what the USMLE is going to do, all right? This is literally urge incontinence when they say this. But apart from this word right here, you need to know that this screening question of does the patient feel the urge to void when sticking a key in a door? Very fucking weird question. I agree with you on that. But that means urge incontinence, okay? And the decreased visual acuity in her left eye, reduced color vision, this is optic neuritis, okay? In the setting of multiple sclerosis. Exceedingly high yield, all right? Very important. So a woman in her 30s who has visual disturbance, she's going to have urge incontinence. This is multiple sclerosis. Now, some students have brought to my attention that there are some resources out there that have mentioned overflow incontinence in multiple sclerosis. Wrong fucking answer, okay? It's not my opinion. It's what's on the NBME exams. Now, if you find some question where there's overflow incontinence in multiple sclerosis on the NBME, not Qbank horseshit, okay? I'm talking actual NBME material. Let me know because I've only seen multiple sclerosis as urge incontinence, okay? Not overflow incontinence. So, and this is our optic neuritis, as I said. So let's just hop through the answer choices. Choice A, conversion disorder, wrong fucking answer. This is psych. This is labella indifference. This is a pseudoneurologic finding in the setting of a stressor. Your classic example is a guy has a fight with his girlfriend, goes to the emergency room, can't move his left arm, and he's indifferent. That's labella indifference. The patient is indifferent or apathetic as far as the neurologic dysfunction. If you can't move your left arm, you'd be fucking worried, wouldn't you? So that's conversion disorder. That's an easy example. Harder, but on the 2CK psych forms, is hoarseness of voice I have seen, and also decreased visual acuity, decreased vision in a patient where they specifically told you there was no relative afferent pupillary defect. If you have decreased ability to see out of one of your eyes, you should have a Marcus gun pupil. If your cranial nerve 2 isn't working, you should have a Marcus gun pupil. So I'm just giving you the heads up there, but let's move through the question. Detrusor hypersensitivity is the correct answer. This is urge incontinence. They can say detrusor hyperactivity, detrusor instability. I mean, this is increased firing of the detrusor muscle. You're going to treat urge incontinence with a muscarinic receptor antagonist, oxybutynin. You can use mirabegarin, a beta-3 agonist, but I've never actually seen that show up on USMLE material, so I shouldn't even bother mentioning it, but some students get hyper fucking pedantic right now. Oh my god, mirabegarin, okay? But oxybutynin, muscarinic receptor antagonist, exceedingly high yield. Oh, and by the way, I mean, I should mention, not only MS, but you can get urge incontinence and USMLE in perimenopausal women, and you can get it in random old women, okay? And patients who have UTI can get urge incontinence-like symptoms. Long discussion, but they can give you an actual UTI where the answer is UTI, there's a fever, there's bacteria in the urine, and they can say she has an intractable urge to void. And you're like, wait, which one is it? Urge incontinence or UTI? It's UTI, okay? Choice C, large residual volume with overflow. I mean, wrong answer, but this is overflow incontinence, okay? So this is classically diabetes, okay? Neurogenic bladder, neuropathy to the bladder. You would treat with bethanechol, muscarinic receptor agonist. Also can be BPH in older men. If they give you elevated creatinine in an older guy, that's going to be, and they tell you increased residual volume, 300, 400 milliliters, that's overflow incontinence, okay? Increased propensity to develop UTIs. You're going to insert a catheter as the next best step. Also drugs like amitriptyline, TCAs, okay, antipsychotics, first generation H1 blockers like diphenhydramine, chlorpheniramine, have anticholinergic side effects, which can cause overflow incontinence. Okay, so high yield for, as I said, diabetes, BPH, and sometimes even cervical cancer if you have impingement on the urethra. Okay, so somatization disorder, wrong answer. I mean, this is a psych condition where they'll generally give you a woman in her 20s or 30s who has recurrent uh, presentations at hospital, different findings where no diagnosis is found. Okay, abdominal pain, gynecologic abnormalities, neurologic abnormalities, a variety of presentations over time. So psych condition, wrong fucking answer in this case. Urethral atrophy, diminished urethrovesical angle. This is stress incontinence. Okay. Now, this is classically increased number of childbirths, G3P3 here, but I mean, the whole presentation is urge incontinence. Weakened pelvic floor muscles. They can tell you downward mobility of the vesico-urethral junction in the vignette. Okay, that can mean stress incontinence. She loses urine when she coughs, laughs, sneezes. And the highest yield point, I would say, is that for stress incontinence, oxybutynin is the wrong fucking answer. Okay, you don't medicate for it. You're going to do pelvic floor exercises, Kegel exercises. Okay, and if those are insufficient, you can do surgery, which is a mid-urethral sling. Okay, do not give oxybutynin for stress incontinence. This is a lengthy discussion, all right? But as a baseline, as a starter, this question, very fucking important for your 2CK. You know the deal. I'm going to continue to make more content. If you like my stuff, subscribe to my channel. And I appreciate your time. That's it.